Here's a BLT sandwich you probably won't want to eat. Borrelia, Leptospira, and Treponema, the three spirochetes we will talk about. Each one of these will be addressed in more detail. For now, just remember that they are technically gram-negative, but they're very difficult to see with light microscopy because of their small size. Although, if you use aniline dyes or a Giemsa stain, you may be able to visualize Borrelia on light microscopy because it is the largest one. Leptospira and Treponema will require dark-field microscopy to be seen. Therefore, other methods are employed to diagnose the presence of spirochetes. Leptospira is a spirochete with two hooked ends. It is transmitted through water contaminated by animal urine from rodents, dogs, fish, and birds. Puddle stomping, working in sewers, and most commonly swimming in contaminated ocean water are some ways that Leptospira can be contracted. This is why surfers and people in the tropics such as Hawaii are much more likely to develop the disease. So be careful when you're out there riding waves. Leptospira causes two diseases. One is characterized by mild flu-like symptoms, jaundice and photophobia, while the other is more severe, known as Weil's disease, characterized by kidney and liver damage. So, if it's test day and you read about someone being around tropical water and then developing kidney and liver failure, think Leptospira. And what do I mean kidney failure? Are the boards going to use the words kidney failure or liver failure? No, of course not. They're not that nice. What they will tell you is that the patient has a creatinine of 2.1 or something abnormal. Well, will they tell you that the patient has liver disease? No, but they will say that the AST and ALT are elevated. INR may even be up. Learn to read between the lines and you will ace these questions. Lyme disease is caused by Borrelia burgdorferi, which is transmitted by the Ixodes tick. You can see the stages of development in the picture here. Lyme disease is particularly common in the northeastern United States, so if you start reading a board question and you see a typical signs of Lyme disease described in a patient from the upper northeast states like Connecticut or Maine, you might want to think of Borrelia burgdorferi. Question: Ixodes tick is also responsible for transmission of which other infectious disease? I'm thinking of Babesia, which causes babesiosis. More on this later. Treat prophylactically with a single dose intramuscular injection of doxycycline in any patient with a known tick bite. Longer courses of oral doxycycline are going to be used in patients with observed erythema migrans rash and IV ceftriaxone for patients with later manifestations of the disease. So, what are the signs and symptoms of Lyme disease? We know the geographical distribution, but what are the classic features we should look for? Well, the first finding you'll see is the rash, which is known as erythema chronica migrans. It is usually described as a bullseye appearance that expands and it's associated with flu-like symptoms. On your exam, you may see it described as a red rash with a central clearing. The central clearing here in the middle. However, it will often just have a central area that is darker or lighter than its surroundings, but not necessarily clear. Remember this rash and think Lyme disease when you read about it. Lyme disease progresses in stages, and the second stage involves the neurological system. But there's a very specific thing that happens. Can you remember what the neurological finding is in Lyme disease? I'm thinking of facial nerve palsy, cranial nerve 7. What does the facial nerve innervate? Well, it innervates all the muscles of facial expression, so you'll see drooping of the corners of the mouth, maybe an inability to raise the eyebrows. Hang on just a sec, I thought these were symptoms of a stroke. How can we differentiate between a facial nerve palsy and a central process like a stroke? A little throwback to the neurology section here, but remember that the forehead muscle, the frontalis, actually receives upper motor neuron input from the contralateral hemisphere. So, if the entire half of the face, including the frontalis muscle, is weak, then the only explanation is a peripheral lesion such as the facial nerve. However, if the lower face is weak but the frontalis is spared, meaning that your patient can raise their eyebrow like this, then suspect that a stroke has happened. Your facial nerve is actually okay. Also, as a part of the second stage of Lyme disease, you can see AV nodal block. Remember from your cardiology studies that there are 3 discrete types of AV nodal block: first degree, second degree, and third degree. You'll see more of this in the cardiology lectures, but let's do a brief recap of the important points. First degree AV nodal block just involves prolongation of the PR interval. Here's first degree nodal block here. There's a PR interval there, lengthened, lengthened, lengthened. Now, how long is too long? Well, anything larger than 1 box is over 200 milliseconds, and that is the upper limit of normal. You can see here that these PR intervals are long. Second degree AV nodal block has 2 types, Mobitz 1 and Mobitz 2. Mobitz 1, or Wenckebach, involves a progressive prolongation of the PR interval until a QRS is dropped, which you can see here. Your PR interval is increasing, 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 and then dropped QRS. Mobitz 2 involves dropping of the QRS unrelated to the PR interval. So you can see here, you have a couple dropped QRSs. Third degree nodal block is a complete dissociation of P waves from the QRS complexes. Here we have complete disarray. QRS complexes here, we have P waves here, everything is just in disarray and things just can't seem to sync up. Okay, so the third stage of Lyme disease involves the musculoskeletal system. You'll see migratory arthritis. Hopefully you'll catch it before it makes it all the way to the third stage though. And what about treatment? We've identified Lyme disease, so what is next? Well, in most patients, a course of doxycycline should do the trick. But how about in a pregnant patient or in a child? Well, in these populations, you'll have to give amoxicillin since you wouldn't want to give doxycycline due to its teratogenicity. There's a great mnemonic in your book that will help you remember the key findings of Lyme disease. To recap, we see a facial nerve palsy that is typically bilateral, migratory arthritis, cardiac block, which we just covered briefly, and erythema chronicum migrans. You can't fake a key lime pie. Syphilis is a sexually transmitted disease caused by the spirochete Treponema pallidum. It is transmitted through sexual contact, contact with open chancre, or transplacentally. Like Lyme disease, syphilis is categorized into 3 stages: primary, secondary, and tertiary, in order of progressive severity. Primary syphilis will manifest as chancre, which is a single, non-painful, indurated ulcer with smooth margins, which can form on the anus, mouth, penis, or vagina. Can you think of a sexually transmitted disease that presents with a painful chancre? I'm thinking of Haemophilus ducreyi, which causes chancroid. This one has a very painful ulcer. And what about painful ulcers? That would be herpes virus. Primary syphilis is a self-limited stage of the disease and in fact heals uneventfully, usually within 6 weeks. But during this time it is highly contagious and if untreated will spread to regional lymph nodes. Classically, diagnosis was done using dark field microscopy. Practically, however, VDRL tests or PCR assays are used for diagnosis. We'll discuss VDRL in a moment. Okay, so that's primary. Here you can see the chancre there, again painless. So let's talk about secondary syphilis. Secondary syphilis occurs about 1 to 3 months later and rarely coexists with the findings of primary syphilis. Patients will present with flu-like symptoms or even meningitis and a very classic maculopapular rash that involves the palms and soles. I make a special emphasis here because there are only a few diseases that cause a rash affecting the palms and soles, and syphilis is one of them. So, if you see this, you should immediately think syphilis. One other key finding is the presence of condyloma lata, which are highly infectious, white, wart-like lesions on the genitalia. Tertiary syphilis does not occur until decades later. It is also called neurosyphilis because of the common neurological symptoms that it is associated with. You will classically hear of a patient with a high stepping gait, and they'll also tell you the patient's feet slap on the ground. What is the term for the clinical picture I'm describing? It's called tabes dorsalis. That's right, tabes dorsalis occurs because of degeneration of part of the spinal cord. Hang on just a sec, little neurological correlate coming. You'll cover this in more detail in the neuro chapter. But which part of the spinal cord is responsible for vibration sense, proprioception, and fine touch? I'm referring, of course, to the dorsal or posterior columns, seen here. The dorsal columns. Now you can see in the picture here that demyelination of the dorsal columns preferentially affects sensation, proprioception, and causes ataxia. Well, hang on one more second. We aren't done with that neurointegration yet. What two vitamin deficiencies can also affect the dorsal columns? Let's say you check a CBC, you find red blood cells with an MCV of 107. So you've got a patient with a macrocytic anemia and neurological symptoms. What's your diagnosis, doctors? Vitamin B12 deficiency. Excellent. B12 deficiency. See, now we're even inviting hematology to the party. Okay, GI is feeling a little left out. Where is vitamin B12 absorbed? In the terminal ileum. Terminal ileum. Okay, let's bring it all together, folks. Your board question is this. You've got a patient who presents with some neurological symptoms of decreased vibration and position sense. They've got a macrocytic anemia on their CBC, and you ask them some more questions, and they've had intermittent fevers and bloody diarrhea for the past few weeks. What inflammatory bowel disorder are you going to consider? Crohn's disease. I love it. We just integrated neuro, GI, and hematology all at once. This is how the boards makes questions, guys. Excellent. And the other vitamin deficiency I'm thinking of? Well, deficiency of this one can cause increased red blood cell fragility. So you might see hemolysis. I'm thinking of vitamin E. Vitamin E, which normally acts to protect red blood cell membranes from free radical damage. So vitamin E and B12 deficiencies can cause demyelination of the posterior columns. And the infectious process that can also cause this, of course, is syphilis. Okay, moving along. In addition to tabes dorsalis, syphilis also causes a very peculiar finding on ocular exam. What is this finding called? It's called the Argyll-Robertson pupil. Right. I'm going to dedicate a whole slide to this topic, so I won't go any further into it right now. Just hold on this thought for another couple minutes. There are a few other findings we have to talk about before we leave this topic. What is a cardiac complication of syphilis? The answer, aortitis. Right. Aortic insufficiency and ascending aortic aneurysms are a complication of syphilis infection. Why does this happen? Syphilitic infection actually affects the vasovasorum first. Remember that these are the vessels that supply the adventitia blood vessels. So, if we have a blood vessel here, and let's say this is the lumen, the outer part of the blood vessel is actually supplied by its own series of blood vessels called vasovasorum. Once the vasovasorum become obliterated, ischemia to the blood vessel wall occurs, causing weakening of the outside. This causes aortic aneurysm. Finally, gummas can occur. Gummas are granulomas of the bone, skin, and viscera. So one could even say that tertiary syphilis causes basically a nagging infection. Remarkably, syphilis is one of the few remaining infections that is still responsive to some of our early antibiotics. So what is the treatment of choice? Penicillin G. Excellent. But you must warn your patients about the Jarisch-Herxheimer reaction. More on this in a few minutes. Congenital syphilis usually leads to stillbirth or hydrops fetalis if the baby survives. It has characteristic features such as notched teeth, a saddle nose, and saber shins. These are all major buzzwords that can show up on your test. So, to remember some of the later effects of untreated syphilis, I like to remember that syphilis causes a nagging infection. Remember that the normal pupil response to light is constriction. When we see this, we say the pupils are reactive. Okay, great. But remember also that there is one other way to get the pupils to constrict. and this is by asking the patient to focus on something very, very close to their face. This is called accommodation. But patients with neurosyphilis can't do this, can they? No. You test accommodation and no problem. You see pupils constrict, right? Then they come back. But what happens when you shine a light in their face? Nothing. The pupils don't react. What is this condition called? This is called the Argyll-Robertson pupil. They used to call this the prostitute's pupil because they would say that like a prostitute, these pupils accommodate but don't react. A slightly off-color memory trick, but maybe it'll help you remember. VDRL stands for Venereal Disease Research Laboratories. This test, or the RPR, the rapid plasma reagent, can be used to initially screen for syphilis. As you learned in biostatistics, an ideal screening test should be highly sensitive, and the VDRL test is. It detects a non-specific antibody against beef cardiolipin. This is an antibody produced by a patient with syphilis that reacts in vitro, meaning in the test tube, to the extract of ox heart and turns positive about 1 week after infection. There can be many conditions that cause a falsely positive VDRL, and here's a mnemonic to help you remember them. Remember, viruses, drugs, rheumatic fever, and lupus can all cause false positive VDRL. To confirm a positive VDRL result is syphilis, do the FTA ABS test, the fluorescent treponemal antibody absorption test, which is highly sensitive and specific for an anti-treponemal antibody, the earliest antibody to appear after infection. Okay, flash quiz time. A 7-year-old boy returns from a school-related camping trip in northern Connecticut and develops fever and headache. Skin exam reveals the following rash. What is our diagnosis and what is the treatment? Okay, so our image shows a red circular rash with a central area of clearing, almost appearing like a target lesion, right? And the history of being in northern Connecticut should make us think of Lyme disease. Lyme disease. It's caused by the spirochete Borrelia burgdorferi. Remember that in children and pregnant patients, the treatment is amoxicillin because of the potential toxicity associated with doxycycline. Sometimes treatment can lead to an adverse reaction due to lysis of the treponemes. Let's say you send your patient home with a prescription for penicillin. What might you tell them to prepare for during the first 24 hours of treatment? Well, in the first 24 hours of treatment, it is very common to develop fever, chills, and myalgia. This is the Jarisch-Herxheimer reaction, a common response to brisk treponemal lysis in response to antibiotic treatment. As the treponemes, which are pictured in blue here, are met with the thunderous force of penicillin G, they lyse. They die, and in doing so, they release lipopolysaccharides, which you can see here, illustrated in the graphic. Systemic inflammation ensues until your body can mount an immune response.